Hello and welcome to our live event tonight, IVF webinar this time. Welcome back. I hope you can hear me loud and clear. I'm your host, Caroline, and I'm here back with Dr. Nadia Caroppo. Hi, Dr. Nadia. How are you feeling today? And let me know if you can hear me.
Yes, I'm hearing you very well. Thank you for being there. It's a pleasure to be here with you once more.
Excellent. Happy to have you back with us. And of course, just let me remind everyone that we are gathering here every single day, as you already know. And this is our second live event tonight. And those events have been brought to you with the help of our ambassadors and partners. And as always, I want to thank them for their support. You can see all of them right here. As you can see, lots and lots of those ambassadors and presenters. So huge thanks to them. And this is all possible as well thanks to them and our top experts, as Dr. Nadia Caroppo, and she's here with us tonight with another topic, a very interesting topic, and I'm sure many of you will find it very, very useful. And just let me discuss a little bit on technical side. So, of course, we will start with the presentation on my IVF cycle phase. So, what can I do next? And Dr. Nadia will start with her presentation. This will take approximately 25-30 minutes. After that, it will be time for your questions. Remember, all you need to do is just type in all the questions in the chat section, and then Dr. Nadia will answer all of those questions to you. So don't miss your chance to ask any questions you have in mind. I'm sure there are plenty of those that you have in mind. So go ahead and do it. And well, I guess that is it from me. Dr. Nadia, it's, as I mentioned, always a pleasure to have you back with us. Thank you also for supporting our initiative, and thank you for joining us tonight. And are you ready to begin with your presentation?
Yes, thank you, Caroline. First of all, I see Fiorella and Guillermo. A big hug for you. And thank you all for being there. Okay, today we are going to start with a topic that it's very interesting because most patients have maybe 1, 2, or 3 failed IVFs. So their big questions is what is going wrong and where can we um, get better results and how we can get better results. Okay, I'm Dr. Nadia Caroppo. I'm part of the team at Equipo Juana Crespo in Valencia, Spain. Our specialty is very complex cases of IVFs, treatments in patients with recurrent IVF failures. Okay, so this is a topic it's very recurrent for us. Okay, so we will start. And I just wanted to do an introduction, just because sometimes we say, okay, I had a bad luck, okay, with my IVF cycle. And yes, chance of course, can explain 2 out of every 3 cases of implantation failure. But what happens with the third part of implantation failures, okay? Mostly when we have causes of implantation failure, most of them are part of embryonic failures, okay, because failures of the embryos, okay, like in a 60 to 70%. But also we can fail in the way we perform the IVF procedure, in the way we stimulate patients, in the way we prepare them, or because we are missing other causes, okay, that can lead to an implantation failure. So the real challenge here is to understand where sterility comes, where the patients, the couples, or the woman's sterility comes from, just to understand where we have to go and where we have to just work a little bit more to be successful. Okay, so we have several definitions of implantation failure, and here you have a chart where you see that implantation failure is the impossibility of obtaining a clinical pregnancy with a transfer of at least four good quality embryos of 3 different cycles. Okay, so these are all data from women under the age of 40. Okay, and of course, the less embryos I transfer, the more chances of implantation failure. Why? Because A lot of patients have other causes that can prevent them to get pregnant if we transfer only one embryo, okay? And also the quality of the embryo is a very important factor, okay? Because if I have very poor quality embryos, of course, the chance of implantation is less, because the quality just tells us the potentiality that that embryo has to implant, okay? It's not talking about a healthy embryo, but the chances for it to implant, okay? So this chart you see is what is, it's a comparison between a group of postpartum women, okay, who got pregnant by themselves, and the comparison is an egg donation program in women. Why? Because we have good, healthy, young oocytes, sorry, okay, and embryos. So we can compare that there's a population that you can compare. And you see on your left, okay, that most of the couples in the first 6 months of searching for a baby, they got pregnant in 65%. The same thing happens with egg donation programs, okay, when there is no other factor that affects implantation. So you see that most of the most fertile couples get pregnant in the first 6 months of searching for a baby, okay, and nearly 90% of couples get pregnant throughout the first year of search for a baby, okay, in the natural pregnancies, because there's nothing more powerful than natural pregnancies, okay, reaching a natural pregnancy. But the curve, when you compare it with egg donation programs, and this was done in 15,000 more or less cycles of egg donation program, you see that the curve more or less is the same. Okay, so when you transfer 1 to 5 embryos of belonging to an egg donation program, 65% of couples get pregnant. Okay, and that percentage increases, to nearly 85% when you transfer up to 15 embryos. And from 15 embryos onwards, the curve flattens. And it's the same thing that happens with natural pregnancies. And you see that they are very similar. And why? Because you have other factors like the womb, okay, your uterus, that can affect it may be a cause of not getting pregnant, okay? And this does not vary according to semen samples, okay? If we have a good normal sperm count, okay, even belonging to a sperm donor, the graphs and the potentiality of pregnancy rates is not altered, okay? So we see that even changing the sperm donor does not account for different percentages, okay, in pregnancy rates. So what happens when we transfer an embryo? Okay, there's dialogue between the embryo and your endometrial lining. The endometrial lining is the cushion embryos just attached to, and they just invaded, okay, and then start to scratch on the uterine wall to implant, okay? So there are a lot of molecules secreted by the embryo, molecules secreted by the endometrial lining, and on the other hand, you have the uterine functionality. So those 3 factors account for a good implantation, okay? So the 4 graphs you see, okay, the drawings account for what happens with an embryo when it's placed inside the uterus, okay, even in a natural conception, okay? So on the other hand, when we talk about uterine functionality, you see that this curve that was published by Dr. Macklin just shows us how very hyperfertile uteruses behave and how hostile uterus behave, okay? Hyperfertile uteruses just get pregnant of any embryo that passes by, okay? And here you see most percentages of couples who undergo a miscarriage. Why? Because they get pregnant even of abnormal embryos, okay? And on the other hand, you have very hostile uteruses they are very, very difficult to get pregnant. And there's much more, we need to select much more the embryos just to make those pregnancy work. And in this part of the graph, we can place all couples who delay pregnancy, okay, because of social factors, etc., or couples who undergo a lot of IVFs and just fail, okay? So as you see, there are a lot of things that account for me to get pregnant. So what can be improved when I do not get pregnant or if I miscarry? There are a lot of things, okay? We can try to improve oocyte quality, sperm quality, embryo quality, the embryo transfer, that it's very, very, very important. And of course, not only having the primary materials like oocyte, semen, and embryos, but having the crib, okay, our in vivo lab that has to work perfectly, okay? Because if I don't have an in vivo lab that works, I won't get pregnant, okay? So we have to look to the uterine functionality and endometrial quality and rule out any type of alteration that might affect my IVF cycles, okay? So there are a lot of things that we are just go over a lot of things just to give you a macro vision of what we can do to improve the IVF cycles, okay? So we know that there are a lot of alterations that the woman can have, like altered thyroid function, diabetes, thrombophilias, etc., that can alter the quality and the functionality of my uterus and my egg quality, okay? And I want to mention especially endometriosis, because we are seeing lots of endometriosis nowadays, and it's an inflammatory disease it's benign, but as it's chronic and progressive, and as we delay pregnancies, we see lots of women that suffer from it, and we see a trend in worse egg quality, worse uterine functionality, okay, and as a consequence, less pregnancy rates, okay? Let me talk about a little bit, you see celiac disease, lactose intolerance, they are inflammatory disease and immunological diseases, okay, that account also for other types of diseases like endometriosis that has an immunological basis too, then they are correlated between them. But I want to mention something that it's very common, that lots of you maybe have been studied for, that are thrombophilias, okay? And it's something that we tend to study a lot, but we know that a very important percentage of fertile population have thrombophilias. They are not diagnosed and they do not account for IVF failures, okay? So we now know that probably thrombophilias are not the origin of my failed IVFs, okay? They can account for a portion of failed IVF, but they are not the origin, okay? So knowing this and knowing that as a significant proportion of the asymptomatic population have thrombophilias, we have to be very, very careful when we assess couples who have these positive tests, okay? Why? Because we can just build up in an iatrogenic trap, because we sometimes just give heparin or aspirin, okay? And we may provoke a miscarriage because of over treating these patients, okay? Because sometimes not only heparin will help me, but if I have a hostile uterus that it's very fibrotic and I give heparin or aspirin, sometimes my miscarriages can be caused by heparin and aspirin, and we see that a lot, okay? So we have to base ourselves in scientific evidence, and always we have to be very cautious, okay, when we have to assess couples for the need to use heparin and aspirin, okay, during an IVF treatment or pregnancy itself, okay? And we are in a new era in the IVF world, okay, because there are a lot of things that are arising that we are studying that we have to understand how they work, okay? And these are some of the things that I will mention, okay? But it's only the top part of the iceberg, okay? So we have to understand lots of things that mediate implantation, to understand what can we do to help implantation and what inhibits implantation, okay? So we have to be very cautious too when we talk about immunology, epigenetics, uterine microbiome. Metabolomics is the study of the molecules that embryos secrete, okay, that can predict implantation or not. Transcriptomics is the genes that are expressed, okay, throughout changes, okay, in our information, but by other causes, and that can alter implantation. And endocrinology also plays a very important role in implantation, okay? So they are fields that are very new, and we are just studying them and seeing what is very important, what is much more important, and how can modulate all that, okay? So how can I improve my oocyte and seminal quality? Of course, having a healthy lifestyle, okay? We know that all stresses, okay, environmental stress, psychological stress, smoking, a not healthy lifestyle, okay, can alter the expression of some genes. We account for epigenetics, okay, and that can account for a worst quality in my gametes, okay. So environmental factors can influence the expression of those genes, okay, and this may alter the correct functionality of my immunological system and alter implantation, because implantation, as I told you before, is mediated by immunology, okay? And I can alter my microbiome flora, okay, that we know now that we have the uterus is not aseptic, okay, and we have lots of bacteria there that can favor implantation, okay. So we have to manage all that just to make sure that they are correctly they are balanced, okay. We have some protocols, okay, to improve oocyte quality before stimulation, okay. For example, in polycystic ovaries, we see that metformin, that it's an anti-diabetic drug, has a positive impact in oocyte quality. Myo-inositol, okay, it's another molecule that can improve the oocyte quality. In low ovarian reserve, we are giving androgens, okay, before that we see that we have better quality in terms of response also. And in endometriosis, we just go ahead and also give some components such as coenzyme Q10 that can help the machinery, okay, of the oocyte just to be a little bit better. Of course, I can do something for us, for my oocyte, but nature will do other things, okay? So this will account for us a small percentage, not a very high percentage, okay? Of course, personalizing stimulation protocols, because it's not the same thing, as you see there a picture, stimulating a polycystic ovary or stimulating a low ovarian reserve ovary of an aging woman, or with a woman who has endometriosis, for example. And we have to be able, the key factor here is to just search for morphological markers, hormonal levels, and that can be a prognostic factor for my egg quality, okay? We're studying that. We see that worse hormonal levels, like FSH levels, very high FSH levels, can induce a follicular recruitment of very bad quality oocytes. So we tend to personalize according to the FSH and estrogen levels the stimulation protocols, okay? For example, in our clinic, okay? So we have to understand who we have in front of us, which type of ovary we have in front of us, just to personalize a little bit more the type of medicine we do, okay? And of course, sperm quality also can be improved a little bit, okay? But we don't have lots of things. You have zinc, selenium, DHEA, coenzyme Q10, we have also curcumin, okay, that we are using, and we see that sperm count can be increased a little bit, but we just work more on the motility of sperms, okay, with all those components, and we can be able to decrease the DNA fragmentation when we give some antioxidants, okay? But very little can be done with sperms respect to eggs, okay? Key factor here is to have a good IVF lab, okay? I've worked in other clinics, and I have to say that the impact of a very good lab that uses latest technology, good safety measures for the patients, for the embryos, for the gametes, okay? And based in testing the quality markers of biologists, of the equipment, can give us better quality embryos, better blastocyst rate of arrival to blastocyst stage, that's a marker of quality, and better pregnancy rates. So this is very, very important, okay? This you have to take it into consideration when we compare. We see patients who come from other clinics, and then we compare our results, and there are a lot of variations, okay? So this you have to take it in consideration, okay? Embryo selection. Throughout time, okay, when we started just working with embryos, we started just by transferring day 2, day 3 embryos. Then it was a very important progress to see that if we lift the embryos into culture to day 5, day 6, they arrive to blastocyst stage, so it was a good achievement. Then it was work on fragment aspiration. Fragmentation is when embryos just divide, they produce some debris, okay, that before we thought that by aspirating that debris, we could improve embryo quality. Assisted hatching was one of the things that nowadays some clinics do. We do not do it, okay, because we see no differences in the pregnancy rate. Assisted hatching is when you do some micropores with laser in the embryo, in the outer shell of the embryo, just to help it just go out of the shell and improve implantation, okay? There was a great revolution with media culture where it was improved, and we saw that we could have better quality embryos when we improve media growth factors, okay, culture growth factors, okay, and metabolomics was a great improvement because we saw that embryos also secreted substances that made us understand how the evolution was. And today, the very important things we have are PGT, okay, that it's pre-genetic implantational testing, where we can just test the embryos for normality, and with different techniques, okay, and morphokinetics, that it's the embryoscope, okay, when you leave the or the time lapse, okay, when you leave the embryo inside the incubator, and every 5 seconds, every 5 seconds, you get a shot, okay, of a picture of the embryos, and you can see how the division was, if it divided on time, the symmetry of the cells, etc., and that can improve the selection of the embryo that can give us a better implantation rate, okay? So those are the things that we can do to improve embryo selection, okay? Embryo transfer, very important. Lots of patients just tell us that they have painful embryo transfers, okay? And we have very good evidence that you do not have to experience any pain, any bleeding, or any cramps, okay, of any type, okay? You do not have to feel anything. Why? Because if I do not do a very good embryo transfer, the uterus is going to just contract, and it's going to just make the embryos not to attach, okay? It's like I have something there that it's bothering me, and I have to just get it away from me, okay? So class A evidence is randomized controlled trials is the top evidence we have in science, okay? That we have that ultrasonographic guided embryo transfer improves pregnancy rates. We have to use very soft catheters that just caress the endometrial lining. They do not scratch it, okay? and no post-transfer rest is needed, okay? So if you don't go ahead and have rest after the embryo transfer is not a problem, okay? Class B evidence is very good evidence, but it's not top quality evidence. As you see there, we always do a pre-transfer assay because sometimes we have very difficult embryo transfers, and we have to know exactly how to get inside the uterus just to place the embryos, because if we don't do a good embryo transfer, chances of getting pregnant are decreased, okay? And class C evidence is it's just professional interpretation, okay? So painkillers, anesthesia, massages, Chinese traditional medicine, did not prove to be so effective, okay? So all those things we also can improve, okay? And we know that they work, okay? We have to evaluate the uterus, okay? We have to evaluate it for morphology, functionality. We have different types of measures, okay, techniques to see if that can be improved, okay? So I'm going just to go over some things. The most important thing we have is the 2D ultrasound, that is the regular gynecological ultrasound, and you see on your left optimal 2D patterns, okay, of a very good uterus, having normal walls, very good endometrial linings. And on your right, you can see endometrial and uterine patterns that can affect that implantation rate. Okay, so if we have these things, okay, just black spots, irregular linings, leiomyomas, etc., we can have a bad uterus, not a receptive uterus, and that may alter my IVF results. 3D ultrasound can help us assess the inner morphology of the uterus, because we know that there are some alterations, acquired alterations of the uterine morphology, okay, that can alter my implantation rate. So on your right, you see a perfect normal uterus, and on the right hand, you see that the cavities are altered, okay? So these cavities talk to us about some alterations that can give me or miscarriages or implantation failures, okay? So we have means to repair these alterations and make the uterus work, okay? Another thing that we can do to assess the uterus, okay, and the endometrial lining, okay, we have discovered on your right, you see a perfect optimal hysteroscopic pattern of the endometrial linings, okay? And the endometrium has to be a fluffy carpet, okay? Pink, homogeneous, fluffy carpet cushion, okay, for the embryos. All of the pictures that you see on your right, they are altered patterns, okay? And those patterns that just make us believe that uterus is not, the endometrial lining may be not receptive, okay? And we have to do things to repair those, okay? We can have cervical niches because of previous C-sections, sclerosis because we underwent different hysteroscopies with other types of energy like monopolar, bipolar energy, and the uterus, the cavity was burnt, okay? We can have endometritis, we can have our cavity just stuck together and have synechia, okay? So those things can be improved. We have also pelvic MRI. Pelvic MRI can help us assess if the interface, okay, the black part, the black line you see on your right, okay, that's a perfect MRI of a perfect functional uterus. On the right, you see the altered in uterine patterns, okay. We assess these with a pelvic MRI, principally leiomyomas, adenomyosis, okay, that account for a lot of implantation failures. And nowadays we have a lot of information about that. We tend to treat lots of patients with these alterations, okay, and we see good results because we are just seeing which patterns of correct uterus just get pregnant, okay. So this is very important. It's an important part. It's a complementary test we can do. It's not the unique test, okay. We have other things. We usually complement transvaginal ultrasound, pelvic MRI, and usually hysteroscopy if we have some doubts, okay. And Of course, endometrial lining, assessing the quality and the thickness of the endometrial lining is very important. The optimum endometrial lining is between 7 and 10 to 12 millimeters, okay, thickness. The pattern has to be trilaminar, as you see in the pictures, but studies have shown that good endometrial linings that are 5 millimeters thick or more do not give significant differences in implantation rates, pregnancy rates, and miscarriage rates. Okay, so we are looking for a good pattern, okay, through the ultrasound. Sometimes we perform diagnostic hysteroscopy in the consultation room to see if it's pink or not, okay, so we can go ahead in that cycle do the embryo transfer. And of course, endometrial environment is very important, not only the aspect, okay? So I know that if I'm undergoing a fresh embryo transfer after a stimulation and I have high steroid, high estrogen levels the day of the trigger, I can have an embryotoxic environment and I can alter endometrial receptivity. So if we have estrogen levels above 2,500 or 2,000 picograms, okay, we do not go ahead with the embryo transfer because we know that it may fail, okay, as well as if I have very high progesterone levels, okay, more than 1.5 picograms of estrogen levels, of progesterone levels the day of the trigger. It's not a good number, okay, a good value to go ahead and do an embryo transfer. So in those cases, it's preferred to just defer the cycle, the embryo transfer, freeze the embryos, and then just make rest and prepare you in a fresh embryo, in a natural cycle or a substitute cycle, okay, with estrogens, okay. Hydrosulfates account for 50% of reduction in pregnancy rates and a 50% increase in miscarriage rate, okay? So fallopian tubes is very important to assess them because sometimes we see that couples come in with a lot of miscarriages. No one just took care about those fallopian tubes, okay? And we see that they have big hydrosulfates, okay? Second picture you see on your right. Leiomyomas is a very important chapter in these failures of IVF failures because they alter the contractility, they alter blood flow, okay, and they make our uterine walls a lot harder than usual. And in fact, embryos have a hard time just getting and implanting, okay? How many women get pregnant with leiomyomas? Lots, okay? But we have to understand if those leiomyomas are affecting a woman, okay, with more than 3 or 2 failed embryo transfers, okay? So that we have to assess it. We do operate on them. Not all patients are candidate to operate on them. We have to see where they are placed. Of course, the most functional part of our uterus is the follicle part, and if we have lots of myomas there, we have to take in consideration maybe just taking them away, okay? And we have a very important aspect right now that it's developing. It's the ERA test that predicts the implantation window, okay, of the endometrial lining, and Alice and Emma test that just test for the normal uterine microbiome, okay, that can offer a better implantation rate, okay? So these types of tests are performed in lots of clinics, okay? We are seeing in our clinic that we do not perform ERA tests, okay, just only in very particular patients, because we are running some tests ourselves, some protocols regarding embryo transfers, and we see that we can open the implantation window by ourselves, regardless the expression of those genes, okay? And the embryo has a lot to do with that opening of the implantation window. Alice and Emma tests are run in very particular patients because we see that most population, even if they have repetitive Emma and Alice tests that are altered, but we see that the endometrial lining by hysteroscopy is good, we go ahead, okay? We always give them probiotics, okay, just to make those lactobacillus flora be best, okay? But at the tops, okay, of course, we rule out endometritis provoked by microorganisms, okay? And if we are not sure that the endometrial lining has a good aspect, seeing it by hysteroscopy, we do not go ahead with embryo transfer. We just do, we take biopsy just to make sure that there's no chronic endometritis or endometritis provoked by microorganisms, okay? So we do not go ahead until we see that the pattern, the hysteroscopic pattern is okay. So it's not a test. We do it, okay, sometimes, but we believe that if we can be just go ahead and give you some probiotics that can be properly treated, okay? And of course, the embryo and the uterus have a crosstalk, okay? And that dialogue is very important. So as you can see, there are a lot of things that can interfere in that dialogue, okay? And it's not a passive process at all, okay? It's very dynamic. So one cycle is not the same as the other one, okay? The embryo and the endometrial lining has to exchange lots of information, but I have to have a very healthy in vivo lab, okay, just to be successful, okay? So each embryo has a splinter, sorry, that just send messages to the endometrial lining. But of course, the dialogue is favored if I have a good crib, okay? If my uterus is functional, we can go ahead and have a very good results, okay? Well, so when we improve that, we will know that we can be successful. But of course, we have to personalize medicine. Not all women are the same. We do not have to protocolize every single stimulation, every single uterine preparation, okay? Because I am not the same as any other woman, okay? So I work differently. My uterus works differently. And why? Because we have to understand where our sterility comes from to know where we have to go, okay? So that's part of the individualization of the treatments we have to undergo, okay? So this is very important. If you have been present to the past webinar I did, this slide is very important because there is no secret, okay, to be successful. It's the result of just learning from each patient, from our failures, just to improve our results, okay? So we cannot do the same thing all over again, okay? Because I will risk to fail once more. So we have to change how we address sterility in patients who have undergone previous IVF failures, okay? So I hope that this talk was interesting for you. I know that there are a lot of topics, maybe lots of questions will arise regarding particular topics, okay? So I will be pleased to answer all your questions. And if a question is not answered today, I will be pleased to answer them by email, okay? Caroline is going to forward them to me and I will answer them, okay? Excellent. Thank you very much for your attention.
Thank you so much, Dr. Nadia, for that excellent presentation. Lots of information, details, but very useful ones indeed. So huge thank you for this. And you are right, there are plenty of questions ready. So I hope you are ready for them as well.
Yes.
Excellent. So let's go ahead with the question number one. Here it is. I would like to know, when is the perfect day for the embryo transfer?
Okay. Again, I think that the first of all, we have to follow the days, okay, of life of the embryos, okay? If I have day 3 embryos, the progesterone I have to have in my body, okay, has to be 3 days old, okay? I cannot go ahead and transfer a day 3 embryo in an endometrial lining prepared for a day 5 embryo, okay? So we have to follow the days of evolution of those embryos, okay? If we have day 3 embryos, 3 days of progesterone. If we have day 5 embryos, blastocyst stage embryos, 5 days embryo, okay? The ERA test sometimes assess the perfect timing, okay? But we see that even with ERA tests not following exactly the days and the hours dictated by that error test, if it's pre-receptive or post-receptive, we have gotten pregnant most women that had error tests with pre or post-receptive endometrial lining. That's why I told you about the implantation window, that we are studying that, and we see that embryos themselves can open the implantation window and we can manage it. Okay, so the most important thing is to follow the days of progesterone. Okay, and they have to match the day of life, the embryo's life, the days of life, of evolution of the embryo. Okay.
Excellent. Thank you so much for answering the very first question, and your question indeed as well. Now let's have a look at the next one. So what is thrombophilia and can it be treated?
Brigitte, yes, I did not explain what is thrombophilia. I'm sorry. Thrombophilias are a group of alterations coming from the coagulation cascade that can alter the functionality of that coagulation cascade. So I can develop microthrombus, okay, and those microthrombus can have a negative impact in what will be the placenta, okay, of the baby, and can create blood clots and alter the blood flow between the baby and the mother, okay. So sometimes heartbeats can stop, okay, because of micro infractions that are caused by those blood clottings, just obturate, closing the arteries and veins of the placenta, okay. But thrombophilias also can cause, for example, heart attacks. I am brain ictus, okay, pulmonary thrombosis, okay. So we can have thrombophilias that have other manifestations, okay, not only related to pregnancies. Sometimes we have women who just miscarry because of a thrombophilia, but those are very little proportion of the population, and they can be treated with heparin, okay, and sometimes with aspirin, okay. But thrombophilias generally are treated with heparin, okay. Just it's a drug that prevents those blood clots to form.
Excellent. Thank you so much for answering another question and explaining all the details. And next question is, are there any techniques or changes that can be made to everyday living to improve fertility for women over 40 when all fertility tests come out positive with no problems?
Okay, age is the best prognostic factor of my IVF cycle. Okay, we know that as we age, embryo quantity and quality diminishes. Okay, and that cut is very arbitrary, but we see that as from 35 years old, women tend to have worse quality eggs and therefore worse quality embryos. So unfortunately, we cannot improve age. Okay, we cannot change our age. Okay, we can have a healthy lifestyle, and sometimes just take those pre-IVF treatments that I mentioned you, that minoxidil, coenzyme Q10, diminishing lactose intake or gluten intake. Okay, that can help us. Omega-3. Okay. Preparations that can help us. Okay, but if we have problems in 40, okay, yes, of course, my embryos may be not healthy, okay, enough. So they cannot, maybe I get pregnant or not because I have not very healthy, abnormal embryos, okay. So we have to assess why you do not get pregnant. If you never got pregnant, being 40, we have not only to assess the egg quality and embryos, okay, study them with a PGD to discard abnormal, chromosomally abnormal embryos, but also study your in vivo lab, okay, because abnormal embryos just get you pregnant, okay. Babies with Down syndromes are abnormal embryos, and they get pregnant. The women get pregnant of Down syndromes, babies, okay, affected by Down syndrome. So you have to be assessed for other factors that may account for your infertility.
All right, perfect. Thank you once again for answering and providing those details to the patients. And well, another question is right here. Do you use human growth hormone in your protocols?
No, we don't use it because we have used it and we do not see better, higher success rates with growth hormones, okay? And they are very, very expensive hormones, okay? IVF treatments are very expensive themselves, and we did not see a better outcome in our results using growth hormones, so we do not use it.
Okay, thank you for the clarification as well. And next question is right here. Are there tests that can let me know if I have a hostile uterus, or any test to know the good or bad quality of the eggs?
Okay, for the second part, because it's easier, okay, we do not know which quality your eggs will have until we do not manage we have them in the IVF lab, and we do not know how they are fertilized and if the evolution of those embryos are correct. Okay, so there's no chance for us to know the egg quality beforehand. Okay, we have some markers just by looking at the morphology of the follicles. Follicles are the houses of the oocytes, okay? That it's what we measure when you are under stimulation protocols. We see that if we have an abnormal morphology, being a very elongated follicle or irregular follicle, probably those eggs won't be top quality. Okay, so that is one thing we have to take into consideration. If you have a hostile uterus, first of all, perform a normal regular ultrasound, measure the walls, see the endometrial lining in the pre-ovulatory stage, assessing it with a 3D ultrasound, and if we have suspects of adenomyosis or endometriosis, just perform a pelvic MRI. Those things we can give us a lot of information. Okay, sometimes when the first in consultation, the consultation visit, when they come to have some information, we also do an in consultation hysteroscopy when we see that the cavity is not normal, or when some women did undergo past hysteroscopies or intervention, and that we have the suspect that the cavity cannot be, it's not okay. So just they have to assess your uterus a little bit more, and eventually the fallopian tubes.
Excellent. Thank you once again for answering this question. Next one is right here. So coenzyme Q10, is it beneficial in those who do not have endometriosis?
We give coenzyme Q10 in endometriosis patients and in patients who are over 37 years old, okay? Because we see that, as I told you before, the egg quality diminishes with age, okay? And coenzyme Q10 has a positive impact in the machinery, okay, of the oocyte. This is the mitochondria, okay? That it's the motor, okay, the engine of the oocytes. Okay, so it's beneficial, yes, for women who have endometriosis, and yes, for women who are above 36, 37 years old.
Excellent, thank you. And how about DHEA? Who would you recommend it for?
For low responders, okay, low responders or low ovarian reserves, we tend to give DHEA in 75 milligrams dosages daily before 1 month or 2 months before stimulation, and throughout stimulation we do give it, okay, to low responders. Not all low responders, okay, but in women, when we expect a little bit more, and we see that the final results in the egg count, okay, are lower than expected, okay, and we give it more or less 1 or 2 months before we start stimulation.
Perfect. Thank you once again. Next question is, how do you prevent asynchronous growth of follicles? Do you do estrogen priming or some other kind of pre-treatment?
We can do good questions. We can give contraceptives before the treatment. We do give them for a very short time before starting stimulation. We do estrogen priming, or we use analogs. Okay, we change protocols. The best protocol to assure synchronic stimulations are long protocols, okay? But we see that lots of clinics are a little bit afraid of long protocols because sometimes you can get hyperstimulated, okay? But if you take all the precautions, hyperstimulation nowadays is very, very rare, okay? You have to adjust doses. So using analogs before also and with long protocols is the best protocol to avoid synchrony.
Perfect. Once again, thank you so much. And quick question right here. Do you use time-lapse incubators at your clinic?
No, at this time, no. We do not use them because we have very powerful biologists in our labs. They have they do a lots of quality checks between themselves, inter-observer, intra-observer, and we see that what they tell us with the morphology of those embryos account for the same results as with time lapse. Okay, we did a mini test in our lab, and we see that we did not have any differences using time lapse incubators rather than using the regular way we see the embryos. Okay, so we personally in our clinic we do not use it.
Okay, thank you once again for answering this question. Next one is ERA test the same as uterus biopsy, and can hysteroscopy be done the same day with ERA? I'm very scared of ERA without anesthesia. Is there any other way to desensitize?
Okay, Anna, look, ERA test is a uterine biopsy. Okay, sometimes you do a hysteroscopy just to check on the endometrial lining, see the aspect of that endometrial lining, and after that, the biopsy is done. It's like a scratch. Yes, it hurts. It's like very powerful menstrual cramp, but it lasts 2 seconds. Okay, literally 2 seconds. Okay, sometimes if you do not tolerate hysteroscopy in consultation hysteroscopy, as mild sedation can be done, or paracervical anesthesia can be injected, okay, and that can help with pain tolerance. Okay, sometimes we use atropine and other painkillers that may help with tolerance, but as I tell you, pain is very, very subjective. So we have to see what you tolerate and what you do not tolerate. Don't be afraid of that. Okay, it's just it accounts for, just believe me, at least 1 minute of your life, and that's it.
Perfect. Once again, thank you so much. Next question is here for egg donation. Which embryo grade should I expect as the best for transfer? Should I request assisted hatching as well?
Of course, if you have a type here in Spain, we classify embryos with letters, okay, A, B, C, and D embryos, okay. First of all, a good egg donation program, you have to have a good arrival to a blastocyst stage. Top quality embryos should be your goal. Okay, so A and B quality embryos should be the gold standard for egg donation. And if you have those gradings, that can give you a pregnancy. Those embryos will give me a pregnancy. And no, my advice is not to do assisted hatching. Lots of embryos, if their quality is not top quality, just doing the holes in the shell, okay, just is like making some pinpoints and some embryos do not benefit of them. Okay, so no, we do not perform assisted hatching at all. Okay, so my advice is not to do it if you undergo an egg donation program. Okay, and get to transfer day 5 embryos, blastocyst stage embryos. That's the goal.
Okay, perfect. Well, actually, there was a question: do you suggest third day transfer? But you just, in such case, best.
No, the gold standard for embryo. We in our clinic we do blastocyst stage. Okay, transfer. We have very good arrival to blastocyst stage, and for egg donation program we never use day 3 embryos, except for very, very few patients that we see that they get pregnant with day 3 embryos, okay, and they account for a very, very low percentage, okay, of our patients in egg donation programs, okay, but the general rule is to go to a blastocyst stage.
Okay, thank you. And so, is it possible to increase sperm morphology? How is it possible? Our doctor suggests us microchip, and it is finding best sperm for treatment, and it is an enough solution. Do you have additional advice?
Okay, sperm morphology is not, we cannot change the sperm morphology, okay? What your doctor suggested, the microchip, fertile chip, or the adnexin columns, okay? It's a way to select sperms who do not have fragmented DNA because of the oxidation process that sperm undergo from when they are formed till they are ejaculated. Okay, so fragmentation, DNA fragmentation in a sperm count, okay, account maybe for worse quality embryo and more fragmented embryos, okay, but you can only do microchip, fertile chip, okay, in normal counts, okay, and normal motile sperm counts with normal count and normal motility, okay? Because if you have one of those two parameters that are diminished, you are not a candidate for doing fertile chip, okay? Because you lose a lot of sperms, and the best way to select sperms, okay, with single strain DNA fragmentation is just by choosing them when you do the microinjection, the intracytoplasmatic microinjection. The same biologists choose the best sperm you have, okay, and that diminishes already the DNA fragmentation. Double strain DNA fragmentation is much more complex, and we do not know yet which type of test, okay, if my fertile chip or the adnexin columns is best, okay. Some other doctors, when there is a high fragmentation of DNA, suggest testicular biopsy, okay. We personally do not do fertile chip, okay. We do not have different results by using them or not using them, okay. So personally, we use it in very, very few patients.
And thank you. And the next question is here. After 6 embryo transfer resulting in 3 failures, 2 early miscarriages, and 1 corneal ectopic, would you recommend having an ERA test done, or is this not needed due to implantation occurring 3 times? Thank you.
Wow, Michelle, this is a very powerful story. Okay, first of all, a corneal ectopic pregnancy is very rare, but when you have ectopic pregnancies of any origin, okay, being tubal, ampular, cervical, it means that that embryo has escaped your uterus because your uterus is not correctly prepared, okay, or the fallopian tube of that cornual ectopic pregnancy was not correct, not healthy, okay. And your miscarriages, your early miscarriages, also talk about your uterus. So I don't suggest to do any ERA test nor any other test, because the problem is not the understanding of the embryo with your endometrial lining, because they attach, okay, but it's studying your uterus from another point of view. Maybe you have adenomyosis, maybe you have some other uterine malformation, acquired uterine malformation that can account for the 2 early miscarriages and the corneal ectopic pregnancy. Okay, so my advice is not to do an ERA test because it's not the problem of attaching or adhesion, okay, of the embryo. So ERA test is not useful for you. You have to be studied from another. Your history has to be seen from another point of view.
Okay, thank you so much for that advice. And well, there is another one. First one is I have had 4 implantation failures, 1 early miscarriage at 6 weeks on immune protocol, even though no immune issue identified. Had ERA map, scratch all donor. Would you recommend any further testing? Current set to keep me with same protocol.
Another powerful story.
Yes.
Immunity nowadays dictated by immunologists. We do not have any type of agreement of what helps or not. Okay, immunologists tend to use heparin, aspirin, um, um, corticoids, steroids, okay, metformin, some other things. Okay, we give lots of patients receive corticosteroids, but we do not know what we are suppressing. If the good immune system or the immune system that does not account for a good implantation. Okay, so um, scratching is not advised. There's no evidence right now that helps. The area mapping, you had a miscarriage, so your embryos got to stick. Okay, I think that your in vivo lab is somewhat broken. Okay, so I think that you have to be studied also from another point of view, just from the functionality and morphology of your uterus, your fallopian tubes. Do not stay with the same protocol because if you failed more times, it's just doing the same thing to fail again. Okay, so you have to search for some advice just to understand what they have to change, just in order to make everything work once more. Okay, I'm not for against immunologists. Okay, don't misinterpret me. Okay, but we do not we have some things that we do not agree with, and in lots of international congresses they do not have any consensus. Okay, so immunology, just we have to take it in consideration, but to nowadays we do not know what works and what not does not work. Okay, so mm, just you have to get studied from another point of view.
Okay, thank you again for that advice. And next question is, so do you use culture media with growth factor added? Example, does your clinic use media such as Embryogen, Blastgen, sequential culture media with GM-CSF?
We use no in our we use we tested some culture media. We are currently testing, comparing to the current media we use. Um, uh, but granulocyte GM CSF, we do not use it in culture media. Okay, we just adjust. We just compared the quantity of amino acids, glucose, oxygen levels, carbon dioxide levels, pressure, temperature, etc., that the component have of that those media have, and we compared them with blastocyst stage arrival and quality, embryo quality, and we are not using embryogen or blastogen. Okay, we are not using those type of media.
Okay, thank you. And there are two questions about ERA test. Okay, so first one is, how is an ERA test performed? And the second is, in planning hysteroscopy and ERA test, does it make sense to do 3D ultrasounds as well?
Okay, the ERA test is a biopsy that is performed when we are in the luteal phase, okay, where just right after ovulation. It can be done in a natural cycle or in a substitute cycle with estrogen and progesterone, just to see if the endometrial lining expresses some receptors that may imply that the window of implantation is occurring and when it is occurring. Okay, and it is done with a biopsy. It's like a scratch. Okay, so it is done to see if those genes are if those receptors are expressed. Okay, regarding the second question, you can plan hysteroscopy, can be planned the same day. Okay, just to see how the endometrial lining is. Of course, luteal phase assessment of the endometrial lining is not the same as pre-ovulatory endometrial lining, what we assess is the pre-ovulatory with hysteroscopy. When we go ahead and see the morphology of that endometrial lining, is just to see the pre-ovulatory phase. Okay, if you do it in a post-ovulatory phase, in the luteal phase, the assessment is much more difficult because we do not know what is normal or not normal right now. Okay. You can do it, okay, because maybe they want to assess the cavity, that you can do it, and afterwards perform the error test. Does it make sense to do an ultrasound, 3D ultrasound as well? Yes. Okay, they are complementary tests. Okay, so we do it. We always do 3D ultrasound when a patient comes in from the first consultation, just to understand how the inner cavity is. But that is not ruling out factors not to perform a hysteroscopy. Okay, so hysteroscopy sometimes has to be performed to assess other things, not only the cavity.
Excellent. Thank you so much once more for that explanation. If the tubes have been clipped, is there any chance that there is still some hydrosaplings in the uterus?
Okay, good question. Clipping of the tubes, okay, is done when we have very difficult surgeries to be performed. For example, with deep endometriosis, and we cannot take away do a salpingectomy. Okay, take away the tubes. You just clip them from the beginning of the tube. Okay, from the proximal part of the tube. Yes, of course, if you clip, you can have hydrosalpinx in the distal part, but if you clipped it correctly, the chances for that fluid to go back and reflux inside the uterus is very low, okay? But sometimes we see it, okay? And how do we see it? When you have continuously a slight quantity of liquid inside the uterus, okay, in your in your ultrasounds, okay, and sometimes after maybe you got pregnant and you had your tubes clipped, when your uterus stretches, that clipping can just go away, okay, and maybe if you had a hydrosalpinx, you can have a new manifestation of that hydrosalpinx, okay. Yes, you can have it, but if it does not bother, it's not a problem.
All right, excellent. Thank you. Once again, next question is, how would you open the implantation window? Is that possible to do?
We have some studies going on. Okay, we have preliminary results. We are using different type of protocols. Okay, just in natural cycles, and we are seeing that women get pregnant even if we do not use triggers to make ovulation occur. Okay, so yes, it can be done. We have preliminary results, very good results. We are going to present them in the Spanish Fertility Congress, and afterwards, eventually, we will present them in the European and American congresses. Okay, yes, it can be done, but we have preliminary results yet, and the results are very good. Okay.
Perfect. Once again, and which type of probiotics would you recommend?
Probiotics, we use probiotics with high counts of lactobacillus. Okay, you have lots of type of lactobacillus. You have Lactobacillus plantarum, etc., etc. Here in Spain, we have one that it's called Dona Plus multiflora. No, Dona Plus flora intima. That has lots of lactobacillus, okay, and we use it throughout endometrial preparation to make sure that, and before endometrial preparation, to make sure that we have a good flow of lactobacillus, okay, but make sure that you have a good quantity of lactobacillus. There are lots of lactobacillus, okay. The one that accounts for most types of lactobacillus will be the best.
Okay, perfect. And there are two questions on frozen transfer. So first, frozen transfers also follow that 3 or 5 day rule. And next one, is a frozen transfer more successful than a fresh? And if yes, why is that?
Okay, for day 3 or day 5, frozen embryos, yes, we have to follow the rule of the days of progesterone. If I have a day 3 embryos, I have to have 3 days of progesterone. In my cycles, day 5, 6, or 7 embryos, you can transfer embryos in day 5, okay, regardless the day of if it's day 6 or day 7, but you have to have at least 5 days of progesterone. Yes, we have to follow that rule, okay? You cannot transfer a day 5 embryo in an endometrial lining prepared for a day 3 embryo, okay? And respect to the second um, question, okay, frozen transfer with fresh embryo transfer. It depends on a lot of things, okay? It's depending on the cause of sterility. If the cause of sterility is a main factor at home and I have perfectly good healthy embryos and my uterus is perfect, okay, in the assessment we can go ahead and have a fresh embryo transfer, okay? Frozen transfers just account for a small part of the population, okay, who have hyperstimulation or who have to undergo different surgeries to correct uterine defects or fallopian tube defects, okay, and we have to freeze embryos, okay. There was a trend to just freeze all the embryos, okay, some time ago, because we saw different studies mentioned that there were better results, but today we know that fresh embryos or frozen embryo transfers have the same pregnancy rates, okay. They have maybe different implications throughout a pregnancy, okay, because frozen embryo transfers can give you a high rate of preeclampsia, okay, for example, in pregnancy, okay, during pregnancy, but in terms of pregnancy rates are the same.
Okay, perfect. Next question. Two of those actually are regarding the donors. So what is best egg donor age, 20 or 26 or 32, with own child or not? And one more is actually in regards to the situation right now. How is your egg donor database on COVID-19 periods?
Okay, first question. Our donors are all under 30, okay? And if they have had any own child, they are proven donors. So yes, they are good donors, okay? Regardless that, if we can assess the ovaries and see that follicles are if they are regular, if they have a good count, if the donor has a good body mass index, a healthy lifestyle, etc., most probably those eggs will be good quality, okay? Of course, some donors don't have good quality eggs, but that we will know eventually when we create the embryos, okay? So it's better, though egg donor programs include donors until 35 years of age. We do not include after 30 years. We do not have any donors. Only very, very, very good donors that are only reserved for international patients, that because they have had by law all the live births the Spanish law dictates. Okay, so maybe they are just reserved for international patients who have to undergo egg donation programs. And regarding the COVID database, okay, here we are doing strict protocols, okay, with PCR testing in all our donors when they start stimulation and before they undergo the egg pickup, okay, just to make sure that we do not put them in a risky situation, okay. We haven't had any donor affected by COVID, okay, and we know today that coronavirus COVID-19 does not live inside follicular liquid nor in sperms, and it does not eventually affect the embryo, and it does not cross the placenta. So that's good news for all couples or women who have to undergo egg donation programs.
All right, perfect. Thank you once again for that clarification. Now we have a bit of a longer question.
Okay.
So it's a bit part of the previous one, but is it possible to perform hysteroscopy in the same cycle as ultrasound? I have had ERA, but no hysteroscopy. Would like to transfer frozen embryo this cycle if possible, but in any case, would like to do all the necessary tests. Which test would you recommend? I now have CD3 and will see my new doctor on CD10 for first long appointment and ultrasound. I have had 11 embryo transfers and nine let in pregnancy, but unfortunately stillbirth in pregnancy week 36. Now proceeding to embryo transfer 12.
Oh, okay, and I'm sorry about that. Look, hysteroscopy can be done. In fact, we do it to assess the if we like. Um, if we see something that recalls our attention in the endometrial lining preparation of the cycle, we want to go ahead and with embryo transfer, you can do hysteroscopy and you can go ahead and do the embryo transfer on that cycle, okay? But you have to make sure we have to make sure that we do not damage the endometrial lining, okay? So if no damage is done, yes, you can go ahead. ERA test in the same, of course, in the same cycle of possible embryo transfer does not have to be done. Okay, it's not possible because I'm going to scratch an endometrial lining, provoke bleeding, and blood plus embryo is not a good combination. Okay. Um, I do not understand if CD3 is something regarding to immunology or not. Okay, sometimes when we have a long a C-section, a long labor, a very difficult um, birth of the baby with forceps or very long expulsive period, cycle day 3. Okay, thank you for the clarification. Okay. Um, Sometimes the uterus just um, breaks, okay? And breaking means that the functionality is not as good as it was before, okay? So I think that day 3 evaluation of your cycle is good to see some things, okay, like the muscle, the uterine muscle. Day 10 is the best day to assess the uterus, okay. And there in the pre-ovulatory phase, you can assess for endometrial lining quality, the myometrium, your fallopian tubes, okay, and if are any signs of adenomyosis, okay, that is the first thing, an endometriosis, that the first thing that accounts for the loss of functionality, okay. Even if you had the birth was fine, okay, if you had a long labor or a lots of oxytocin, okay, lots of hours, okay, of labor, the uterus can break, okay. um, most stillbirths do not have a cause, okay, unfortunately, okay. So
There's a follow-up question as well.
yes, how is the fallopian tube? Yes, I'm looking at it. So I think that you have to assess, your doctor has to assess your uterus in 3D ultrasound, eventually pelvic MRI, and assessing eventually if something has to be done to treat that uterus to give back its functionality. Fallopian tube tests is done by injecting a contrast and doing an oily contrast, okay, and doing some RX scans of how the liquid passes through the fallopian tubes, okay, to see the caliber of those fallopian tubes, and if they have a free spill inside your belly or not, okay. So that is something that eventually can be done. It's a bit painful, but it's useful if you never undergone, if you never have undergone the hysterosalpingogram, okay, that it's called. It can also be done with gel, okay. And can it be done in the same cycle of the transfer? No, okay. You have the further transfer. Okay, fallopian tube testing is done just after you finish your period. Okay, not in the pre-ovulatory phase, because you can have false positive tests. Okay, you can maybe have results regarding your fallopian tubes being blocked, and maybe that's not the point, but it's just because your endometrial lining is thick and the liquid cannot pass through the fallopian tubes. Okay, I will never have any more oocyte retrieval though. Okay, if you are not going to undergo any oocyte retrievals and you're opting eventually to open a new window with egg donation, first of all, please check on your uterus, okay? Because if you undergo egg donation program, we can fail again, okay? And that's not the point, okay? So please, 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 just make your doctor investigate a little bit more your uterine functionality, okay?
Okay, thank you so much for those recommendation as well. And actually, there is a follow-up question in regards to the clip tubes. You have answered that question, but if you could take a look, if by any chance the tubes have been stretched, does it mean the hydrosalpinx might be the one that can be contribute to the failure of
Of
implantation?
course. Yes, of course. Hydrosalpinx means that liquid is retained in the fallopian tubes, and normally that liquid has to spill to the belly. If for some reason I have a distal blockage of my tubes, that liquid will drain inside my uterus, okay? And that liquid is toxic. So if it's toxic, it can alter the implantation and kill my embryo, okay? So yes, if you have a hydrosalpinx, it's mandatory to resolve it, or by clipping or by taking away the fallopian tubes.
Excellent. Thank you once again for that. And next question is there a big difference in success rates between a frozen transfer and embryo with fresh semen or frozen semen?
It's if the semen, if you use fresh, it's always better to use fresh semen. Okay, why? Because sometimes we freeze semen samples, then when we defreeze them, the quality just is worse, and we don't have quantity to work with. Okay, so if you can use fresh semen samples, it's better. Okay, but sometimes we cannot use it because of lots of reasons, and we have to use frozen semen sample. Of course, if I have worse count, worse motility, yes, it might account for worse embryo quality in the end. So if you have fresh semen sample, better, okay, better embryos.
Excellent. Thank you once again. And I'm sorry, there is a follow-up, sorry, about the question from Nicoletta. Okay, so that would be the solution. How can I verify this? It's regarding the
Yeah,
clipped tubes.
the clip tubes performing a hysterosalpingogram, okay, just injecting, as I explained to you before, the liquid, okay, inside the uterus, and do some shots of RX to see if you have the hydrosalpinx or not. Okay, that's the traditional way. Sometimes you can do a hysterosonogram, the high COSY, that can, it only indicates if you have blocked tubes or not. So it's very difficult to see if you have a hydrosalpinx unless it's a very, very notable hydrosalpinx. Okay, but the most important test to do is the hysterosalpingogram, it's called.
All right, perfect. Thank you once again. And someone is typing. I'm not sure if it's the same patient, but okay, yes, I believe so. Okay, let's wait, and if not, we will just simply get back to the
Okay.
patient on that. And the next question is, do you suggest NGS for all cases and also embryo glue?
We do not use embryo glue, okay, because we did not have different success rates using embryo glue. NGS for all cases? No, no, not at all, because it's not useful, because I know that a 35-year-old woman will have normal embryos. Okay, the only thing that NGS will allow me to do is just shorten the cohort and get to a normal healthy pregnancy before a cohort I did not test. Okay, no, we don't use it always. And Also, we have to know if we will have embryos, predict if we will have healthy embryos or not, a good cohort of embryos to test. Okay, of course, maternal age is one of the most mandatory facts that will be applied PGTA. Okay, and recurrent miscarriages or recurrent implantation failures of lots of embryos, yes, can be we use it. Okay, but if not, it's not. We do not believe that all patients have to undergo PGT with NGS.
Okay,
I
perfect.
think that was the question. We use next generation sequencing
Mm-hmm.
always. Okay, uh, mm, because it's the best test. FISH test that was used before offered lots of normal results that were altered. Okay, so nowadays we use an NGS. Okay, if we do PGTA.
Mm-hmm. Okay, excellent. And there's actually another question on embryo glue. So, if I'm going and doing egg donation, pre-implantation screening, intravenous immunoglobulins, is this too much to also ask for embryo glue? Does embryo glue really work, or is this more of a gadget like?
It's something else that we can offer, but as I told you before, we do not use it. Okay, and our success rates are high, and we do not use it. Okay, intravenous globulins are very discussed. Okay, there are no mm, scientific um, evidence. There's no scientific evidence that they work. They are very, very expensive, and they have lots of side effects. Okay, and mortality cases were reported by using monoglobulin. So just be careful about that. Get assessed if you're going to use it. Okay, if you have a good uterus, you will get pregnant with egg donation. Okay, it's not useful to do all those things. If you're failing with egg donation, check on your uterus. Okay, check on your fallopian tubes. The functionality is very important. I'm sorry, I will be like a broken telephone talking about this, but we see lots of patients that fail 17 embryos belonging to egg donation, and the problem was in the uterus, and we fixed it, and they got pregnant the first time. Okay, and the first transfer. So that's mandatory to do.
All right, thank you again. And next question is, did you say for over 40s with low ovarian reserve should decrease or increase lactose intake?
We use no, always decrease lactose and gluten intake. Okay, but we suggest that not for low ovarian reserves. Okay, we suggest that for patients that have history of endometriosis or adenomyosis. Okay, not all patients are candidate to diminish lactose or gluten intake. Okay, so no, it's not mandatory being over 14 and doing that. It's only mandatory if no, not mandatory. Okay, we suggest to do that because that we see that there is a correlation between the inflammation provoked by lactose intake and gluten intake with inflammation occurring around the uterus because of adenomyosis, okay, and endometriosis. So if you have that, if you have a diagnosis of adenomyosis or endometriosis, yes, I suggest you do that regardless your age.
Mm-hmm. Okay, thank you. And actually, there's another question on melatonin for low ovarian reserve patients. Is 1 milligram a day worthwhile? Can it interact with any of the protocol drugs?
Okay, we give melatonin because we have some products that include melatonin. We include minoxidil, kerinositol, zinc, selenium. Okay, yes, 1 gram melatonin is worth. Not only for low ovarian reserve patients, but also for polycystic patients. We give it generally to all our patients that will undergo a stimulation protocol, and no, it does not interact with any other drug.
All right, perfect. Thank you once again. Next question is here. So I gained 4 kilos after each transfer in short time. Started exercising a lot now. How many weeks before next transfer I should slow down?
You can do normal exercising just before the day of the embryo transfer. After embryo transfer, you can go ahead and have a normal lifestyle, okay? Just make sure you do not do heavy exercise, okay? But you can still exercise a little bit less, okay? Or a little bit less heavy, okay? Heavily that you have been doing right now, okay? But no, there's no indication for rest, okay? As I told you before, yes, in very pathological uteruses, we just suggest bed rest, okay? But it's like very little percentage of our patients, okay? But generally, there's no need to stop exercising, okay? You can go ahead and do normal life until the day of the embryo transfer, and after embryo transfer, go on exercising if there's no contraindication, but a little less heavily, okay?
Perfect. Thank you so much. And next question is right here. I am using donated eggs. Should I still have my fallopian tubes investigated, and would DHEA be any value help? I do not have high testosterone.
No, DHEA for you, if you're not undergoing stimulation protocol, it's not helpful. So you just I don't suggest you to use it. And yes, check on your tubes. Okay. If you have undergone egg donation and you have failed and you have never been tested for the fallopian tubes, yes, get tested.
Okay, perfect. Next question is, I'm taking coenzyme Q10 and DHEA since 3 months. Do you think it will make a difference in my AMH, which is 0.02? I'm 44 and would like to use my own eggs.
No, they won't make a difference in the AMH counts, okay? They can make a difference in the quality we can have, okay? But remember that being 44, you will need a huge amount of eggs to have a normal embryo, okay? My suggestion is if you go ahead and use your own eggs is to get tested for abnormal embryos, okay? To discard chromosomically abnormal embryos, okay? Just go on and take them. They can help you with your quality, okay? But not with the AMH count. That won't be altered. That's unfortunately a product of aging, okay? The lower MH count.
All right. Thank you for clarifying that. Next question is here. I tested positive on rubella value 67.3. Can it be treated before IVF? And S propactin 39.5 and LH 4.8, 23.3. Is there any danger for the treatment?
I think it's prolactin. If I don't, I think it's prolactin. But
Yeah.
okay, rubella tested positive on rubella IgG. It means that you have been vaccinated. Okay, so you don't have to do anything. That's good. Okay, if you did not have IgG positive results, our suggestion would have been to get vaccinated. Okay, prolactin levels you have 39. They're not very high values. Okay, so no, there's no danger in treatment. Okay, what we usually do, prolactin is a stress hormone that can be elevated because of any factor. Okay, so if you had a high level, we suggest to repeat that test after 1 month. Just be calm before you do the test, and if it does go down, it's normal. If the levels are increased or are very very high, then we have to study you eventually to see if there's no the gland that produces that hormone in our brains is not increased in size, okay, and that because that yes can account for alteration, but during pregnancy, not for your during the pregnancy, okay. But now for undergoing an IVF treatment, that value you have, it's not very high.
All right, thank you. And next question is, I am scheduled for frozen embryo transfer. I have a very retroverted uterus at age 44. Is there anything you would or would not recommend, i.e. camera, ultrasound, assisted transfer, etc.? Thank you.
Um, retroverted uterus are a very important challenge. One, because it's very difficult to see them through an abdominal ultrasound. Transfers can be very difficult, and sometimes retroverted uterus are very challenging because their functionality is a little bit worse respect to anteverted uterus. Okay, so what I told you before about using guided ultrasound soft catheters that most clinics have, yes, okay. Ultrasound is mandatory, okay, and soft catheters, okay, and that's it. And you don't have to have experience any pain, okay, or any contractions, okay. You don't have to be uncomfortable that day, okay. But no other suggestions.
Okay, thank you. Next question is, I have had failed IVF with one embryo implanted through blastocysts. I did vaginal ultrasound, this hysteroscopy, fallopian tubes were fine, uterus was normal with 3D scan, endometrial lining was okay. What other problem could there be, and what other tests should I do to rule out other factors that prevent pregnancy?
Okay. First of all, one failed IVF with one day 5 a blastocyst stage embryo, it's not something that you have to worry about. Maybe the uterine preparation was not correct. Okay, maybe they have to change the way they prepare you. Okay, I don't know your age. Because that can account also for a failed embryo. I don't know the quality of the blastocyst they transferred. Okay, I don't know if the transfer was painful or not. If you had some bleeding after embryo transfer, okay, there are some other things to assess. Yes, of course. But if everything seemed normal, just give another shot to another embryo transfer with a different preparation. Okay. If you fail 2 or more embryo transfers of good quality embryo transfer, then yes, maybe you have to be assessed from a uterine functionality point of view. Okay, maybe with a pelvic MRI. Okay, and maybe just seeing the characteristics of the endometrial lining with a hysteroscopy in a pre-ovulatory phase. That those things may have to be the things that your doctors have to study and investigate a little more.
Okay, thank you. And there is a follow-up to the previous question from Summer. Okay, so is that transvaginal? I will show
Hi,
you.
Summer. Sorry, I forgot
Yes,
wait.
sorry,
If
I
you
will
can,
show you
Caroline.
that, of course,
Yes.
just it's right here. It's regarding ultrasound.
No, the ultrasound, no, it's through the belly. Okay. Usually we do abdominal ultrasounds, okay, to see ourselves when you go inside with a catheter, inside the uterus with a catheter. Sometimes we have to go in blindly, okay, because it's very difficult to see retroverted uteruses. Sometimes we do when we have the catheter placed inside vaginal ultrasound, but it's better not to do it when we do the transfer. Why? Because maybe we can damage the endometrial lining. Okay, so if we are not able to go to see ourselves, it's better to go in blindly. Okay, but to do that, first we have to assay the embryo transfer before to know exactly how many millimeters we have to get inside. Okay.
All right, perfect. Thank you once again for that. Thank you for clarifying, Summer. Thank you for adding that. Next, there are a few questions left, but of course we will be slowly finishing. So I guess we still have some time, right, Dr. Nadia, and we can continue.
I see that the questions are popping up.
Yes, it's true. So we will just answer a few of those, but of course, any questions that will be left, we will definitely forward to you so you can
Yes.
get
Of
back to
course.
the patients. Yes.
Mm-hmm.
But let's go and check those three at least. I have had 5 ICSI, one embryo each time, one failed, 3 miscarriages at 5, 7, and 13 weeks. At 13 weeks, the heart stopped. Male normal karyotype. My hereditary thrombophilia screen was normal. Hysteroscopy normal, but retroverted uterus. In March, I did a cycle and got one top blast, but was forced to freeze due to COVID. With only one embryo in, I can't afford trial and error with the implantation window. Would you recommend? Would you have any recommendations? Sorry.
3 miscarriages. And 3 miscarriages talk about your uterus. Okay, first of all, get screened for your fallopian tubes. Second thing, get screened for uterine functionality, not only with the hysteroscopy that you had a normal uterus, a normal cavity apparently, retroverted uterus. If your cycles are painful, okay, they talk about a bad functionality of the uterus, and retroverted uterus generally the you have retrograde menstruations. That means that the menstruation just go inside your belly through the fallopian tubes. That may be a factor contributing to the appearance of adenomyosis. Okay, retroverted uterus tend to age worse than anteverted uteruses. Okay, I think that before you go ahead with the embryo transfer, we have to understand how your uterus works. Okay, because um, three, four, 3 miscarriages out of 4 embryo transfers, okay, it's not a problem of your embryo not attaching to your endometrial lining. It's a problem of the embryo not getting the right blood flow, okay, and that may be because of a hard uterus, okay, and the hard uterus produces as the myometrial, the muscle not functioning correctly, okay. So I think that you have to be assessed from another point of view, okay. So get get tested for the fallopian tubes and get tested, see if you can do a pelvic MRI, get a consultation, okay, just to see what is happening, because it's very, very, very important. You cannot afford to fail once more, okay. It's very, psychologically, it's very difficult to undergo another miscarriage or another negative results, okay. That's my advice, Emily.
All right. Thank you once again. Next question, another quite longer one. So let's have a look. Can Donna plus Flora Intima be used during the natural cycle prior to potential egg collection? Just some clarification. My body did not respond to Pergoveris. The treatment had to be stopped. Before that, after the Pergoveris, I had only one good follicle, which was empty. But as that result of the natural cycle, I had 2 embryos, which did not implant, unfortunately. The doctor recommended not taking any medication but returning for day 7 for the ultrasound because the body responds better without hormonal stimulation.
Nicoletta, I think that you are have a very low ovarian reserves, and low ovarian reserve ovaries are very difficult to manage with stimulation. Okay, Pergoveris is a very potent medication, but if the protocol is not used correctly, you won't respond. Okay, we have to you just see the timing that your ovary has in terms of waking up, and just potentiate that waking up, okay, and push it a little bit more, okay. um, um, Sorry, Caroline, can you go back to the other the question of
Yes,
Nicoletta,
of
please?
course, right here. Sorry.
um, so Donna plus Flora Intima, it does not interact and does not contribute to a better response or to a higher quantity of eggs. It just helps the uterine flora microbiome just to be a little bit better. Okay, and if you have a very low ovarian reserve, yes, of course, some cycles will be good, some cycles won't be that good. You can have empty follicles. Okay. Um, or sometimes the instructions that we give the ovaries just to trigger the ovulation are not it does not reach the ovary properly, and that may be a cause of an empty follicle. Okay, but if you are planning to go on a natural cycle just to retrieve eggs and that works for you, that's okay. But Donna Plus is not going to interfere with that or make it better. Okay.
All right, thank you. And there's a follow-up from Nicoletta. What do you mean about pushing?
Okay, as I told you in a previous slide, okay, very high FSH levels, okay, just tend to show us that that ovary is not functional enough, okay? And if I have very high FSH levels and I give you Bergoveris or whatever medication you want in the dosages you want, like being top dosage is 450 units, okay, of medication, you won't respond. Okay, so we have to see when your ovary wakes up, sorry, in terms of FSH levels and estrogen levels, and when it starts to wake up, we push it with little medication. Okay, you don't need very high dosages medication if you have a normal body mass index. Okay, just to have the same results. Okay, as with very high dosages medication. It's a protocol that it's very personalized. Okay, and we have to play with hormonal dosages just to make sure that we know exactly when the ovary just wakes up. Okay.
All right, thank you. Once again, just checking. All right, perfect. So I guess we will just answer the last question for tonight. Yes,
Yeah.
Dr. Nadia,
Thank
and
you.
I will definitely follow all. I mean, forward all the questions to you and your team. I'm sure you will be able to get back to all of our patients. And well, let me go to the next question. So at which point is recommended the change of a doctor, the clinic or doctor? For example, I did 3 embryo transfer in one country, then other 3 in different one, then other 3 in another one, and now a new in the fourth country. Do you usually recommend following the same doctor and or clinic?
Look, Nicoletta, it's very difficult. Okay, you have to feel comfortable with the doctor, and you have undergone lots of treatments. Okay, so if you don't see that someone can offer you a different view of your problem, I think that you have to search for different opinions. Okay, just to make sure that you get a different point of view, because if you go ahead and do the same things regardless the country that you're in, regardless the clinic that you're in, it won't be useful and you will fail. Okay, sometimes unfortunately we have patients that we see that they have no chances of getting pregnant, but because maybe we have very, very hostile uteruses and we cannot manage to get them pregnant. And sometimes we have to be ourselves the one that have to tell you to stop going ahead and trying to go undergo IVFs after IVFs. Okay, so I think that maybe your story have to be assessed from a different point of view and see if in some other country or some other clinic, just before you go ahead with another embryo transfer or with another IVF cycle or donor cycle, I don't know which type of treatment you are now undergoing. Okay, you can have a different point of view because you know that something is not okay. Okay, and you are the first one to know it. Okay, so if you don't get to um, have another investigation, another thing, something that it's a turning point, okay, in your history, I think that there's no point in going ahead and doing the same thing all over again. Okay, of course we may fail. All of us can fail, okay, because fertility is not an absolute scientific science. Okay, it's not absolute. Okay, we are always in a gray area of fertility. Okay, there's not black or white. So we may fail, all of us may fail, but it's important that you feel that your doctor is doing something different each time, just to understand what might have gone wrong and how he or she can work around it just to offer you a different solution. Okay, that for me as a patient, because I'm also a patient, okay, I'm a doctor, but I am a human being, and sometimes you are a patient. You have to feel comfortable and believe in your doctor and see that he or she is doing something different just to offer you a solution to your problems. Okay, or maybe just tell you, look, all that you've did, all that we will run some other tests, but I see that what you've done and what the other colleagues have done is okay. And sometimes we have to opt for other treatments, maybe a subrogate uterus if you can undergo that, if in your country is legal or not, or adoption or something else. Okay, I don't know exactly what you underwent. I will be glad to evaluate your case if you want me to. Okay, you can always contact us if you want another opinion, okay? Just to see if we can do something for you or offer you something different, okay? I hope you have a bit more of luck this time, okay? Really.
Thank you so much. Exactly. That's what I think. And of course, I just want to remind everyone that all the questions that haven't been answered today, don't worry. I will forward those to Dr. Nadia, and you can use the link I have just sent to you. And actually, that way you are able to also ask any other questions if you have, and this will be also sent to Dr. Nadia and her team. And well, right now, I would like to thank you, Dr. Nadia, for your time. You have been amazing today with all of those answering all those questions. And well, thank you for those questions. Thank you for joining us as well. And I'm sure it has been helpful. And well, I just want you to see there are only good and positive comments. Right.
Thank you very much. I hope it has been useful. Of course, if you want to contact us for any doubts or any question that has not, as Caroline said, has not been answered, I'm sorry. I know it's been like a 2-hour talk more or less. And thank you for all the good feedback that you are giving me. Okay, I am very glad that I could help you. Okay.
Exactly. Thank you so much. And as you can see, there are only more of those comments. So thank you, being so thorough. I just want you to see it. So
thank you so much.
more of
This
those.
is very, very nice. Thank you.
Definitely. But you've been definitely amazing, and I would love to have another webinar with you. It's always a pleasure. So thank you so much, everyone, and I hope to see you tomorrow as well, as we will be back at 6 p.m. UK time and at 8 p.m. UK time. So don't miss your chance to ask more questions to some other experts. And this has been recorded, so of course, again, you will have a chance to watch this again. And if you simply want to get in touch with Dr. Nadia and her team, you just need to follow the link, and I'm sure they will be all helpful. So once again, thank you. Have a lovely, relaxing evening, and hope to have you back here again.
Bye-bye. Good
Thank
evening to
you.
everybody.
Bye.
Bye-bye.